we're going to look at facts and figures. We're going to look at what dementia is, and we're just going to touch on this. I will show you some types of dementia that are the most common ones. We'll talk about diagnosis and why it's important. Planning ahead, summary of all of that, and then I'll go into tell you a little bit about what I do in the community up here in Western Sydney. So, every 3 seconds, someone in the world is getting diagnosed with dementia. In Australia, there is a 250,000 people, 250 people are diagnosed each day. And like that is a very scary number when you think about it. Like it's a lot of people getting diagnosed every day. There are more than 472,000 people currently living with dementia in Australia. And when I say that, I am actually thinking that there are quite a lot of people that haven't been diagnosed that are living out there, most of them in our cultural communities that don't want to or don't even understand what the illness is. So even though that's a number of people that we know about, there's a lot more out there that don't, that aren't registered or that aren't recognised as having dementia. A lot of the times we're looking at this as it's an older person's illness, and I'm telling you it's not. Currently, and this is new figures that have just come out, we have 28,300 people that have what we call younger onset. And so younger onset is anyone under the age of 65. And I've actually worked with people in their 40s that have a diagnosis of dementia. And when we look at it, people think, oh, it must be lifestyle choices and things like that, but not necessarily. So some of it is genetic, but not always. And if you learn anything from today, it's about the diverse range of ways that the people present with this illness and how it's an individual person-centered type of approach that we need to take with each person. Now, by the year 2028, which isn't really that far away, we're looking at over 500,000 people diagnosed in Australia. And obviously, as we get into 2058, we're looking at over 1 million people diagnosed. Now, at the moment, dementia is the second leading cause of death. And the first one is heart disease. Now, dementia is the second leading cause of death because all the cancers are not combined into one category. Each cancer is classified as an individual type of cancer. If they were to, and that's just the way that the ABS collects the data, if they were to combine all the cancers together, then dementia would still be the second leading cause of death in our country. Okay, so when we talk about dementia, and one of the most common things that people ask me is, what is the difference between dementia and Alzheimer's? We talk about dementia being the umbrella term, and it covers every single type, and it is something that affects the brain. It's a disease of the brain. Typical signs of dementia are the way we think, but it's also the way a person does things. It's really when it's impacting their everyday function that we start to look at the types of dementia. No two people are the same, and it is not a normal part of aging. So we talk about it, and it looks like all old people are forgetful. But I know we can't do this as a group because we're a large group. But if I were to ask you how many of you have gone up the street and forgotten to buy, bread or milk or something that you've gone up the street for, have you put your keys down somewhere and not been able to find them? Have you ever parked anywhere and not been able to find your car? They're common things that happen to all of us. It doesn't mean we have dementia. There's a lot of other factors. The other thing to understand about dementia, as I talk about it as an umbrella term, when we talk about fruit, there is a lot of varieties of fruits, and dementia is the same. There is over 150 different types of dementia, and people don't have just one type. They might have a combination of 2 different types, or they live with other comorbidities. So it's not one disease, it's very complex, and we look at each individual with what they present and what they need, and then we try to work with the families to provide that. Okay, memory and thinking. As we get older, the way we think and the way our brain functions is different. This is normal. So it's a little bit like arthritis. You know, if I've been driving for a while and I get out of my car, I'm starting to get older, my body doesn't want to function in the same way. And so that's normal part of aging. And sometimes we process things a bit slower as we get older, but it doesn't mean you have dementia. So how the brain works. Our brain is a really complex tool. Now, you'll be able to look at this in the slides later, but every single part of our brain does different things. So that front part of the brain, it's the organizer. It's where the decisions are made, where we know how to start and stop something, how to behave when we're with other people, working memory. So it actually controls every other part of the brain. The messages in our brain are going back and forward, so we do what we do. Talking, to have insight, to understand something. All that front part of the brain is the high functioning part of the brain. We cannot do anything at all if it's not going through our brain. So moving, speaking, sitting upright, it's all controlled by the brain. Now the temporal lobes, which is just over your ears, and this is just half of the brain. It's both sides that you have temporal lobe, and this is where the auditory processing. So you hear things, you understand language, and you process it, and it goes back and forwards with the other parts of the brains to actually put everything into context. The peripheral lobes, which is sort of the top in the center, this is our sensory processing. It's where we can feel, see, smell, all those things, touch. Our attention, if we have damage in that part of our brain, our attention span might be a little bit different. Reading and writing and calculation is all done in this part of the brain. And spatial orientation. So when I talk about spatial orientation is when you go to sit down in a chair, you can actually see the chair and you can sit down in it. You can sometimes see someone going to put something on the table and they miss, or they go to sit down and they miss the chair. It's because their spatial orientation is affected. The occipital lobe is where our vision is processed. That's at the back of the brain. So what we see, how we interpret what we see, then it goes through to the other parts of the brain so that we're processing it. And then we have the limbic system. So the limbic system, which is in the back of the brain there. So if you can see right at the back of the brain, it forms and processes our emotions and our memories. So emotional content, you'll find that if something has a strong emotional connection for you, it lasts in your memory for longer. And we talk about this a lot when we work with people because sometimes it might be a trigger. For me, I'm Italian. My grandfather was a chef. If I smell something like nice Italian food being cooked, sauces and things, it reminds me of my grandfather. It reminds me of the Christmas meals that we used to have together. Now, I don't think about that all the time, but sometimes that, emotion connected to that smell brings back those memories. And the hippocampus is in the middle and it stores memory from all over the brain. It collects and stores. So we develop memories, we remember things, and then they get stored in this central part of the brain. And it's where our deepest memories are, and our long-term memories sit. And often when we talk about this, when you work with people that have dementia, you find that they may talk about the past better than they can talk about what's happening today. And that's because their long-term memories are actually protected for a little bit longer in their memory. So, symptoms of dementia. People may experience changes in the following, and not everybody will experience the same things in the same ways. And so I need to emphasize that all the way through this. Not everybody will have problems with only their memories, their language. Now, with language, because we're working with a community that speaks more than one language, often they revert to their mother tongue. And it's because it's been in their memory bank since they were children growing up. Comprehension, with language as well. Sometimes people with language can't find words, which is what's most common that we see. But sometimes people with language issues actually speak really rapidly. They talk a lot, but make no sense. So they feel that they're engaging with us and telling us something, but it's actually not making any sense at all. Comprehension, and that means they can't understand what we tell them, and they can't process what we're telling them. Judgment, they may not know when something's right or wrong. They may not feel cold. Like sometimes a carer will say, oh my goodness, my husband's wearing a tracksuit in the middle of the day and it's 40 degrees outside. They just don't have any sense of that. And that may be also because those sensory parts of the brain are damaged. Not able to plan, can't follow instructions or planning processes. Now, behaviors do change for people depending on what's happening to them. And I don't want people to label anyone with a behavior. We really need to look beyond that. Often a behavior is coming from fear, frustration, anxiety. There's reasons why there are behaviors, and we work with what's happening in the here and now for the person to try and keep that person okay. Spatial orientation, as I mentioned, that they can't be able to sit or put something down in a place because they can't. And that spatial orientation can actually even happen with eating. They may look at a plate but not be able to see it all. You might have to move the plate around in front of them so that they can actually see. Sometimes they can only see half of the plate, not all of it. And mood and personality changes sometimes. Now, mood and personality, if you think about what's happening for someone who feels confused and disorientated, no one understands them, we would also be anxious, might have mood swings and things like that. Some of the dementias do cause it as well. So it's quite a variety, and not everybody. Some people say, oh, my mum used to be very religious, always went to church, and now she's swearing like a trooper. That is because they have no inhibitions. They have no understanding of what's right and wrong anymore. So sometimes that does happen depending on the part of the brain that's affected. Okay, as I mentioned before, there's over 150 types of dementia. These are the ones that are the most common, that we see the most, that we talk about the most. And if you're interested and you go on our website, you will see that there's other ones that you can read about as well. But these are the ones that we see predominantly in the community. So Alzheimer's disease is the one that is most common, and I'm going to show you what they look like, because I really want people to understand that it is a disease of the brain and it looks different. For those of us working with people with dementia, for me, because I understand the illness, it does help us to understand how to work with the person, but it also helps us to understand why they may be doing some things. Vascular, Lewy bodies, and frontal temporal, they're all very different to one another, and we do have different ways of working with people that present with those. Now, when we're looking at someone with Alzheimer's disease, and as I said, it's the most common, and what it looks like is, as you can see in the pictures, the bigger picture has got these big splotches on it. And how I like to explain it, the bottom picture is a brain where all the messages are getting through really well. And if you see, it's clear, and it's like an electrical, let's say it's electrical wiring for the house. And you've got all the electrical wiring and all the messages are running around the house and your lights and everything works. And all of a sudden you have a fuse that goes out. Now, that doesn't mean that the rest of the house stops functioning. Where the fuse has burnt will cause the damage, and you see the blotches, and that's the damage in that section. But depending on where that is in the brain will depend on what a person can and can't do. What people mostly present with when they have Alzheimer's disease is that they may be repetitive. They may say the same thing over and over again. It's because they get stuck. They can't move on to something else. They need a bit of help with that. When you're looking at the brain as a whole, you see these blotches in the brain, but it's also shrinking. So the brain is starting to get smaller as well. And people with Alzheimer's disease, usually as they present, it'll be more that they forget recent events. So if I ask someone, what did you have for breakfast this morning? They probably will tell me something like, oh, I never get fed here. The food's terrible. No one ever feeds me. Whereas you know that the wife has cooked and they have eaten. So we can't always take things at face value because they do forget recent events. But if I were to say, how was it when you were working? They might be able to tell me a whole history of the type of work they did and where they worked. So that's where this one is a little bit different to the others. Now, vascular dementia is to do with our heart. And like we talk about good heart health, and looking after our heart actually keeps our brain functioning well as well. So this is more after a stroke, and I think we relate to strokes as when you see someone that maybe has been more impaired physically. You may see someone that's affected down one side of the body, and you can visually see that they've had a stroke. But with some of the vascular types of dementias, they're little mini strokes, which are only very minor. Sometimes they could be sitting and sleeping or look like they're sleeping, but they've had a mild, stroke, which will cause damage to wherever that blood flow has happened. So there's a blood clot or a blood flow issue. There's leaking of blood in the brain. It's only in the sections where that damage is. The rest of the brain functions quite well. But it can affect planning and judgment, memory, attention, again, depending on the part of the brain that is affected. With someone with Alzheimer's disease, it's a progressive, slow condition. So usually, and there's no normal, the word normal really doesn't exist in my world, because there's no normal process, but Alzheimer's disease tends to be slower. So if someone in their 80s gets Alzheimer's disease, you'll see changes gradually over time. With vascular dementia, if we can't stop the blood, the strokes and the mini strokes, then you will see like a step down type of change. It looks like they're functioning okay, then all of a sudden something happens and they can't function again, and then they deteriorate a little bit, then they plateau and they are okay for a while, and then they may have another little mini stroke that may cause their functions to change again. And as I said, like behavior does depend on where in the brain those mini strokes are happening. Now, with frontal temporal, this one is a little bit more complex in the sense that that front part, so if you look at the bottom picture, the back of the brain is really quite plump and healthy still, but the front of the brain is actually shrinking and damaged. And so the messages aren't actually getting in there or processed properly. This does cause problems with behavior. They lack empathy. So if one of my carers is really, really sick and feeling unwell, a person with dementia will not understand that that person is unwell, that there's something wrong with them, because it's really about their own needs. They become very focused on what they need, very inflexible. They lose inhibition. So that means it might be okay in your household to drop your pants in the middle of the lounge room and go into the bathroom to have a shower, but you wouldn't do it in front of strangers. A person with dementia doesn't have any inhibitions. They will do inappropriate things in inappropriate places just because they don't realise, because there's damage in that part of the brain. The other thing that they could do, I'm a bit chubby and I might be going for a piece of cake, and someone might say to me, oh my goodness, don't you think you're a bit fat? You shouldn't really be eating that cake, which is 100% correct. But normally a person wouldn't say that to you because they may feel that it was offensive, and they don't have any barrier there. They will say things inappropriately and not realise that it could be offensive. They become obsessive as well, because I think because there is this damage and they're losing control, they become really, obsessive with things that they're doing. The other part of the frontal temporal is that they have trouble finding words and the meanings of words. They have difficulty in producing speech. And it is really, like, I have worked with people that have this type of dementia. It is heartbreaking to watch because they are quite aware that they're trying to engage in a conversation with you and tell you something, but those words aren't coming through for them. And so obviously there are ways that we work with them to try and make them still feel supported and reassured and not stressed, because then the more they stress and the more they become agitated about the fact that they can't speak, the harder it is for them to actually get words out. Now, Lewy bodies, again, is different. Now, it's called Lewy bodies because it was named after the specialist that found this condition. Lewy bodies, if you look, they're the brain cells that we were looking at before with all the little antennas going off. But in this one, the abnormal structures are inside the brain cell. And so that causes different types of concerns for a person, and they fluctuate from presenting really quite well at times to being extremely confused. And with Lewy bodies, they often hallucinate. So they will see things like things crawling up the wall. It can be misdiagnosed because of that. And it does take, thorough investigations from the geriatricians to be able to pick it up. But they will see things. They become very concerned because they're worried that people are going to attack their families or whatever, and it's quite real for them. The other thing and the other reason why this one sometimes gets mixed until they do thorough investigation is that it is similar, or it looks similar to Parkinsonian disease. So that stiffness, that rigidity with the movement, it also is part of Lewy bodies. And so sometimes people with Parkinson's do develop Lewy bodies later in life, but people do have Lewy bodies without Parkinson's, and that they then start to have difficulty with their movement as well. Okay, younger onset, and why is this difficult to diagnose? When people present with younger onset, doctors aren't necessarily looking for dementia. Initially, they're looking for mental health issues. They're looking for other things that they're trying to diagnose and to correct. Unfortunately, once they, and for a person that's younger, this can take 7 or 8 years before someone actually recognizes that it is a dementia. Now, people that are younger have other complications that maybe someone over 65 might not have. And part of that is that they're probably still they're still employed, they have children at home, they're driving, they might have a mortgage. It does impact in a very different ways. We actually have people at Dementia Australia that just work with people that are younger because they need a very different type of support, and we still need to engage them because often they're very physically fit still. It's just that their brain is starting to be affected. They can have Alzheimer's, they can have any other type of dementia as well. And so we are developing services that are actually more suitable, because you can't tell someone that's 45 that they're going to go to daycare and be with a group of 60 or 70 or 80-year-olds. They have other needs. And so it is really important that when we identify someone that's younger, we start to look at the needs and what sort of support they need to still be functioning in the community. So our older people are funded through My Aged Care, but with younger people with dementia, they're funded through the National Dementia Insurance Scheme. And so they need help with setting that up, just like our aged population needs help with My Aged Care. Younger onset also need help with the NDIS to understand that process and how to get services in place, care plans that actually work for them properly. Okay, so the dementia experience. The person with dementia is our focus, and we work with each individual to make sure that we're matching what their life expectations are or were. So with each individual, health and physical fitness is important. You need to see how they are with health and physical fitness. This will sustain. So these things that we look at as a whole for individuals helps us to keep a person well. So making sure that their health is okay, making sure that they still remain mobile and physically fit. There's neurological damage to the brain, so we understand that, and it's different for every person. So understanding what type of disease they have, how it's affecting them, so we can work with that individual. A person's personality is so important, and so for me as a community worker, knowing how this person is and how this person functions, and it goes with the lifestyle hand in hand, or life history. If you're a positive, proactive person, you will approach the disease in a very different way to someone who may have been always pessimistic in their life. Lifestyle history also takes into consideration, what did a person enjoy? For those of us that work in the community, and I'll talk about the community and the clinical in a little while in my talk about my service, but for us in the community, what was important to this person? How did they work in life? What sort of personality did they have? Because just because their memory isn't working doesn't mean that this is a different person. It's the same person. And we just have to work around the things that are suitable for that person. And social psychology. So What are their networks? What are their social supports? What are the things that, do they belong to church groups that help them to function? What is it about this person's social life before the illness that may help us while they have in this process that their brain is changing? If someone was always a social person that liked to be with people, then we try to make them engage with people, and we educate the people around them to how to be with the person with dementia. But if someone's always been a loner and doesn't like groups, then a group might not be appropriate for this person. So we just need to work with what each individual needs. It's so important that we remember that what works for one person isn't necessarily going to work for everyone. I know we've got quite a few people on our session today, and if you just think about yourself and people around you, even in your own family, what works for you? Would it work for your brother, your sister, your mum, or your dad? And they're the sorts of things that we always have to keep in mind. Now, causes of confusion. Now, this is just when we feel confused and disorientated. If you're overtired, and for many of us that work in the community, we are overworked and we do get very tired. Stress and anxiety. Last year through COVID and still this year, how many people have been very anxious, very stressed, very worried about family? We might not be able to go and see family in other suburbs or states. There's grief. And when we talk about grief, it's not just death. And I like to remind people that we grieve throughout our lives for lots of reasons. You may lose your job, you may lose a friend, you may have to sell your house and move somewhere that you didn't want to. There are lots of things in our lives that cause grief. Pain. A lot of us live with pain daily. It's just how we manage it. But a lot of pain can actually make us appear um, confused and not wanting to engage with others. Depression. A lot of people live with depression, and it's, how do they live with depression? If they are down and very sad and non-responsive to things, they may appear like they have dementia, but they're really depressed, and that can be confused for dementia sometimes. With medications, and this is very common, especially with our older communities, they may be taking medications for 10, 15, 20 years and maybe not taking them the right way, maybe taking them more than they should or forgetting to take them. If we don't medicate ourselves the way we're meant to medicate and have reviews, then this can cause confusion. Nutrition deficits. Now, it might be easy to just have a sandwich or a piece of cake with your coffee and not eat properly, but our brain to function needs exactly the same things as our heart. It needs good, healthy food, natural products, a little bit of meat, a little bit of, maybe a lot of fish if you can eat fish because that's good for the brain. We need water. You'll see dehydration is another one. So people with deficits will become confused if their body's missing out on some of the vitamins and minerals that their body needs. And with dehydration as well, if we're not drinking properly enough fluid, we feel tired and lethargic. And for those of us that work in offices, often that's something that's really drummed down to us. Get up, walk around, clear your head, go outside, get some fresh air, and drink water because you do become tired and lethargic and could get confused. Now, when we talk about infections, this can be any type. We talk about urinary tract infections that may be something that you don't know someone has, but may make them be more confused than normal. Now, a person with dementia who has an infection often appears like they've actually gone off the radar with their confusion. Often carers think that they can't support them anymore because they don't know what to do. But once we get them to have tests to get checked out and the infection is cleared, then the person comes back to how they were before. With sensory problems, if a person can't see well or a person can't hear you properly, it is really hard to know whether it's a dementia or whether it is actually confusion because they're not able to hear or see us. A lot of people take their clues from our body language. Our body language is more important than language sometimes when you're working with people with dementia. So it is really important to know whether the person can see properly or whether they can hear you well, because otherwise we may feel that they are confused and have dementia, whereas it's not a dementia. Now, all of these things on my screen are things that can be fixed. So these are all reversible causes. And that's why it's so hard for doctors to actually pinpoint. There is a variety of tests that need to be done to make sure that we eliminate these things. Because once these things are cleared, then the person won't be confused. They'll be thinking better. So the importance of diagnosis is, and the diagnosis, the GP, you can talk to the GP, but he is what the word says. He's a general practitioner. And so if you had cancer, if you have a heart condition, he will send you to a specialist. If you have memory issues and you have some of the symptoms that are indicators, then it is important that the GP sends you to a geriatrician. For younger people that aren't in the age bracket of the geriatricians, deal with people that are older, and they look at the whole body and everything that's happening for someone that's old. But sometimes the younger people will go to a neurologist that works with the brain and what's happening in the brain. You will be asked to do blood tests, urine tests, brain scans. These are the things that the doctors need to look at to see if there are any of those other things that can be fixed. So those other issues that we talked about in the past slide are things that are reversible. So the doctor is looking at, is there one of these other things causing this problem? Or when they look at the brain scan, is there something happening in the brain? Now, sometimes the doctor will not want to name it straight away, and that's because for every person it does progress differently. They may say that the person has mild cognitive impairment, and if the right services and supports and structures are in place for some people, it doesn't progress out of that stage. They are manageable and okay in that stage, but you will find that a geriatrician will do a 6 monthly and yearly review. They will do all those tests again. There's a thing that they call the mini mental, which is really complicated, but they'll do all these tests for our cultural communities. They have other tests that they do because language isn't their first thing, so they'll do other types of tests. But they want to compare from now to 6 months' time to a year's time before they actually label what sort of a thing or what sort of a dementia it is, if it is a dementia. There are medications. Now, there is no medication that will stop the illness. But there are medications, especially of those people in the early stages. People with dementia are probably struggling the most because they're aware something's not right. They don't know what it is. They become very anxious and they're very worried and very scared. And there are some medications that do help those people in that stage. So it is important to get in there quick to give them a bit of support so they don't have that anxiety and pressure. It also gives the person with dementia and the family time to plan ahead. And that's really important. And there's so much around, us understanding what is important to the person with dementia, because we want to work with what makes it better for them. And so planning ahead, if they present early, and I guess my wish list would be that everybody that has any sense of not being confused, being worried about their memory would present, so that we can eliminate things, but also gives you the opportunity to talk about what is important to you in the future if you can't tell us. So planning ahead is a big component. Okay, so just in summary for this first part of my talk, dementia is a disease of the brain. It's not just someone putting it on, you hear carers say all sorts of things. It is actually affecting the brain, and we can see it in brain scans how it affects. It affects everyone differently, so never put people in the same bucket. We are all different. I tell people, heaven help any nursing home or service provider that gets me as a customer when I get older if I get dementia, because I will be wanting to run those services. I've been doing it for 30 years. That's who I am. So, people trying to put me in a bucket with people with dementia, not knowing my history, they struggle with me. We need to treat everybody as they present because they are all different. It does progress over time. Different dementias progress in different ways. So the Alzheimer's might be a slow progression. Some of the others might be more rapid. There's so many factors in there. And often because people have comorbidities, it's often, not just the dementia. They may have a heart condition. They may have other issues. There is no cure at the moment. But, if we give people the right type of support in the community, we can sustain people for a very long time living really well, as long as we can support the person with dementia and their carers. It's the biggest goal that we have, because we can make life still good. You don't need memory to have a good time. So with people with dementia, we live in the here and now. We have good times, moments of good time. They might not be able to recall what they did today, but you know that they're okay and they're safe and they're happy. And that's really important, because it makes it easier for carers as well. Now, that's the end of my first part. So does anyone have any burning questions that they'd like to ask now? I'm just going to go back to Fathy and see or Lisa, and see if there's anyone that would like to ask any questions now.
Thank you very much, Nina, for the first part. That was so informative. I really appreciate the hard work you put in to prepare this. Look, quite a lot of questions did come through, but you answered most of them within your presentation. So I just made sure with the interpreters that if those answers were sufficient, and most of them said yes. So thank you very much. I've got a lot of great comments coming through as well, saying how informative you are and how well presented this webinar is. So thank you. Just passing that over. One question did come through, and I think you're going to potentially touch on this in the second part of your presentation.
Sure.
I've got an interpreter here saying, I did one assessment involving an Alzheimer patient. The professional kept asking, what's the meaning? I couldn't understand, and she couldn't accept that the interpreter was interpreting in the first person. What can I do?
That's very bad on the part of the service provider, but and I will touch on interpreting in a minute. You can only relay back what the person is saying, and obviously the person with dementia may not make sense, but we need to understand the words that are coming from the person with dementia, and then if the person that is your service provider, if it was me, rather than ask you what the meaning is, I'd say, can you get him to tell me a little bit about that? You know, we want to be able to make it easy for the person with dementia to understand the meaning. You can't interpret a meaning. You need to get that from the person that's talking to you. So, you know, the person with dementia may be really frustrated or agitated, or they might be saying something that doesn't make any sense at all. And that's because of the dementia. So there may not be an actual meaning, and not knowing really what the context of the whole conversation is, I wouldn't even preempt it. But the person that you're interpreting for, if you were interpreting for me and I'm unclear, I wouldn't be asking you to give me a meaning. I'd be asking the person with dementia or the carer another question to see if I can explore a little bit further to get it. I need to be the one to find the right words to get a sense of what's happening for that person. It's not really the interpreter's place.
Nina, you're the ideal professional. I mean, you know how to work with interpreters, and I wish all service providers were like yourself. Having said that, I think you know, it's all about education, it's all about training also the service providers with the interpreter's role. And yes, the institutions, organizations need to provide training, but as interpreters, I believe that it's also our responsibility to train and educate service providers. So if we have a look at the AUSIT Code of Ethics, maintaining professional relationships, it states there, interpreters foster a mutually respectful business relationship with the people with whom they work and encourage them to become familiar with the interpreter or translator role. Okay, so it is actually a part of our code of ethics to educate service providers about the interpreter's role as well. In regards to first person interpreting, yes, you know, especially with this, when it's face to face, we should be interpreting in the first person, but when we're telling the service provider about the role of the interpreter, perhaps at the start with an introduction, we can say to the service provider and the non-English speaking person as well, that we'll be interpreting everything in the first person, so that they are aware, and they are aware of how the session is going to be conducted or interpreted, so that they're not surprised. So there's a little bit of a recommendation for us interpreters out there. Do an introduction introduction about how you will interpret, and if they ask why, it's easy, it's more direct, and less mistakes are made, and it's quicker when we interpret in the first person, and it actually builds that rapport with the service provider and the non-English speaker as well. So those are the reasons behind it if you need to give advice or train the service provider within regards to that. Nina, thank you. I'll hand it back over to you.
Okay, and I'm going to touch on some of that too from my own personal experience. As I said, I am Italian, and when my dad does have dementia, so I'm happy to disclose that there's not a problem with that. He's 91 today, actually. But when I went to the geriatrician with Dad, I actually asked for a professional interpreter to be present, and then became extremely unhappy because the interpreter wasn't working with what the doctor was asking, but was trying to push Dad to remember stuff. And I kept saying to the interpreter, that's not what the doctor wants. The doctor wants Dad to say his way, and Dad's extremely deaf. So there are things around like, having the interpreter understand, and I'll talk about why that's important as well. So in Western Sydney, the Primary Health Network had some funding to put in place a Dementia Care Navigator specifically for the cultural communities and diverse communities. And for those of you that aren't in Sydney, Western Sydney is probably our most diverse part of Sydney. So other parts of Sydney may have a lot of Italians or Greeks. In Western Sydney, we have a very large melting pot of communities. And so they felt that a called specialist would be good in that area to try and support people that aren't presenting and needed help. Now, so that's basically what I said. Like it's a very mixed community, and you need to go into that community with a very open mind. It's about government. My service supports people to understand what government funding is, what services are in the area, and how to connect. And I help them with all of that. And I can be as involved as they want me to be. And I can provide them with, I can refer them onto the government funding, like my aged care or the NDIS, or I can connect them to the service providers. And I can come in and out. The luxury that I have with this position is that the funding doesn't come directly from the government. It is through our primary health network, and their full focus is to make sure that we get out there and provide as much help as we can, which is something I'm very passionate about as well. So it's a really good union that we have. I work very, very closely with that network, with the primary health network and the health teams in our area. So you will, in some areas, you will have what we call dementia advisors. My role is a bit different, but I work very closely with my advisory teams in my area. I'm asked to join panels in the area as a specialist for core communities. Now, because we are a PIC body, and ethically, I could not say no to anyone. I had a discussion with Went West, who fund us, the Primary Health Network, and I said, I am primarily for core communities, but if I get someone that speaks English and is from an Australian or Anglo-Saxon background that doesn't understand the paperwork, it is my duty of care towards them to help them as well. And I do, and they're okay with that, because ideally all we want is for the community to be supported. It was or is a 2-year trial. This is 18 months into the project. It has been extremely successful even through COVID, which has been quite a surprise, but probably busier through COVID because I'm available all day, most days. But we're looking at if this model can be actually increased or developed more or funded in, ongoing, and not just in Western Sydney, because we think that there's a need everywhere in this country. The benefit for the client is that you are going to get a dementia specialist. I've been in the industry for a very long time. I've worked across different programs, across different organisations. So part of my roles have been within health, part of my roles have been in community services. I've managed programs. So you will get someone that understands systems and processes and people and how they work. It is primarily for people from cultural backgrounds, but as I said, or special needs groups, but I will not stop at that. I will help anyone that needs support. Initially, the program was set up for me to actually do some group sessions to talk about dementia, similar to today, but also to connect people to understand funding. And so my navigator role when I'm speaking to carers will also include not only the understanding the dementia process, but I will also talk about what my aged care is, what it does, what services you can get through that and why you need it, and what the NDIS is and how that works. I also talk to people about what services are in the community and what they do. Now, I had very successful seniors group sessions prior to COVID, and we didn't know how we were going to move ahead with that. But there are many people, I think we tend to forget that our older communities live with younger people who know how to use the internet. And so there are a lot of seniors groups that are actually meeting online. They might be doing exercises online, they may be just touching base with one another. So there's been some organisations in Western Sydney that have done that really, really well for their communities. And I've been invited to do presentations to those people on Zoom, which has been really exciting and really great. I also can work with residential aged care facilities. Now, you'll hear language, you'll hear people that are funded for a specific thing or a specific age or a specific area. And it is really difficult because people, it's not that they don't want to do the work, it's that they are guided by their guidelines for their funding. I am lucky that I can actually work across age groups because it's about the disease, not the funding. Um, Unfortunately, yes, it is in Western Sydney, but I can actually support people that are already in residential care. I can support carers with the transition from community to residential, but I can also help carers understand or support them even through the changes in residential care and if they have issues there. So the flexibility that I have has been really, really amazing and really good. The other benefit to my clients is that I do one-on-one. Like I sit with them, I talk through what they want, and then we look at how can we get it. And look, what we want for our families may not be achievable. That's just a realistic, thing about community services and support. But they're honest, open conversations that we have. Let's try this and see how it works. So I do work with individuals. I am going back to face, so I can go and visit people in their homes, and you do get a better picture of what's going on if you can go and do a home visit at home. But through COVID, I've been able to support over the phone or online forums. The other thing that happened through COVID is that if a service provider or an assessor has gone to the house to do an assessment, I can join in via Zoom or a conference call and provide the dementia expertise for the family and the service provider. So those are things that have been really beneficial for the client, that I've still been available even through these really difficult times. Hopefully, if we have navigators across areas, you'll be able to focus on what's local. And that's the specialty part of what I do for my clients, is that I then do the searching in the local area, connecting to all the networks that I have to find the right service for this person. Because I work with a peak body, apart from being an expert in this area, I'm also very unbiased. It's not about who I want to refer them to, it's who can do the best job for this person. And I engage with the providers, and there might be 2 or 3 providers in the area. I will approach all of them and see what availability they have and how they can do it. And then we work with the carer, look at, okay, this is what's in the community, what would you like? So it's about, not one service giving them everything. Sometimes you need to explore more than that. Now, at our organisation, another benefit is that we have a lot of translated information available. I can work with interpreters, and I do. If I have to get an interpreter in, I will work with the interpreter. I can support people from any ages, I've already said. And it's not just I can work with the person with dementia in the early stages. They often have quite a lot of input into their care. I can work with families, and their siblings and conflict. I can work with all of that. But there's also friends. There are people in our community that don't have family, and they may have a key important person that they trust. So we establish who those people are, and then we work with them. It's not only someone that already has a diagnosis. I also work with anyone that's worried about their own memory or about someone else's memory, so that we explore, Is it dementia? What else do you need to know? Because that, hopefully from what my first presentation showed, it's not clear cut. It's not straightforward. There's so many other things. So people can come to me and say, I'm a little bit worried about mum or dad or me. And then it's about me saying, okay, let's take it one step back. What's been happening? Tell me a little bit about what's going on. Why are you worried? Okay, working with interpreters. Now, this is going back to that question that was there. For me, need to have clear information translated and facilitate provider states in provider states. So for some, if something's not clear, always confirm with the provider to clarify. So what I do when I have to have a session, I will contact the interpreter first, and I will give them a rough idea of what I'm trying to do so that I can orientate you to the expectation of my interaction with this person. I then work with the interpreter to understand, that we need, from the person with dementia, we need to understand what their responses are. And then if I need clarification on that, I will clarify with the interpreter what I'm trying to find out and try to get to that point. So if something's not clear, it's not for you guys as interpreters to try and figure out what the person is saying, because you're not going to have expertise in all the areas that you're going to be asked to interpret in. If something's not clear, it's up to me as the person that's doing the interview to clarify with another question, another way of asking something, so that can come. For myself, I don't want an interpreter to add or leave out anything. Anything from the way the person responds, because with dementia, the way a person responds actually gives us a bit of understanding of where they're at. And I'll give you an example. My dad, I saw him on the weekend. He's in residential care. We were talking about something, and he's engaging. My dad's dementia is extremely different from anything I've seen in all the years that I've worked. But my dad was a musician, very creative, so his brain functions differently. Now, we were talking about stuff, and all of a sudden he said, oh, I'm not going to be here for much longer. And we thought he was talking about death. And then he turned around and he said, I'm 20 now. I'm going to be 21 soon, and I'm going to have to do the military service, because that's what they used to do in Italy. Now, if I had not heard a bit more of what Dad was saying, I might have thought that he was talking about death. And an interpreter may interpret that the same way. But we really need to, because for me, when he said that he was 20 and 21, it just told me that that's where he was in his thinking at that moment. I mean, he still recognized who I was, so obviously he's not 21 if he's got me and I'm 61. But that's why it's important that you don't add or subtract anything, but that it's for me to try and clarify what that means from them. Now, you will find when you work with interpreters with people in the community sector and clinicians, it will be different. The clinicians will be after a more medical type of thing, whereas in the community, I'm more important for me to find out historical stuff and who this person is. So you will find that will be very different. When I book an interpreter, I always make sure that I give myself 15 minutes before and 15 minutes after, because I think it's important to talk about I know a lot of people are scared about dementia, so a lot of interpreters that I've worked with are like, I don't know what to do or say, or what is this person going to be like, because we have this terrible image of someone with dementia. And I reassure them and I tell them. And then at the end of the session, we also have a little bit of a debrief about how that was for them, and if I could have done something different, or if they felt that there was something different that could be done. I think that part for me is really important, that a little bit at the beginning and a little bit at the end, to just put it all together. Now, I guess some of the challenges and some of the achievements in the 18 months so far, we were hoping to get people as soon as they were diagnosed and support them from the beginning with this project. But what we're finding is that we're getting people that are very complex, very high needs, and a lot of them are just bouncing out of hospital at the moment and things like that. The other thing, I was really keen, and part of this is my fault, I was very keen when we got the funding to just get it up and running as quick as possible. And we tried to make it as easy as possible for referrers to send referrals through to me. Unfortunately, referrers have been sending very minimal information, which makes it really hard for me to actually start the process. So sometimes I will need to know if it's a male or a female because I don't know from the name whether it is a male or a female. I need to know an age group so I know what I'm addressing. I need to know an address. I need to know a language. So there are things that interpreters have been, that referrers have been a little bit slack with, and if we can get this model funded, there are guidelines that I will put in place to make sure that that doesn't happen because that takes up valuable time trying to search that information. The community groups that we've been able to do, so the sessions that decreased because of COVID was disappointing because obviously we were getting nice big numbers of, 30 or sometimes 40 or 50 people in a room that could engage with me, face to face, which is always a lot better. But we have been able to move that to Zoom, and that's been, I guess, for me, really exciting to see that we've still been able to connect. The other thing that has been very positive about COVID, I guess, is that because of COVID, people can join in from Zoom from anywhere. And so I have had siblings, one in Western Sydney, but the sister living in Queensland, who both care for mum and want to know what to do better. And so because of the Zoom platform, we were able to talk face to face, the three of us, and discuss their issues and their concerns. So the support over the phone and via Zoom has actually increased, and it's actually gone broader than we thought it would go. Now, just for you to see the diversity in action in Western Sydney, these are the countries that the people that I have seen in the last 18 months come from. So you can see quite a mixed variety of communities that I'm working with across Western Sydney. Some of them are only little small clusters and others are a big population. So it's really important to see when we talk about diversity, this is what it looks like. The languages that I've been working with over the last 18 months, these are all the different languages. So you can see it is very diverse. I don't speak all those languages, but I can work with families that sometimes there are family members that speak English really well, and that's okay. Sometimes the people with dementia still speak English, but we do need to prepare for when they can't. So that's it for me. I just want, if there's more questions, happy to answer. The other thing, I'm happy if people would like to email me directly. I'm happy for Fathy for you to share my email address. You will receive in your kit my name, our organisational details, the referral pathways. But you'll also, if you get stuck and you just don't know anything else, you can ring our helpline. Because our helpline, which is on the screen now, you just have to say, we need to talk to Nina in Western Sydney. They'll know who you're talking about. Or you might say the Western Sydney Navigator. They'll send a message through to me. So that national helpline covers the whole country. So all the phone calls come to that 1-800, 100, 500, and then they will pass it on. For those of you that want to find out more or look for more information, I have put together some sheets that cover the dementia part of it for you. But if you go on dementia.org.au and you look up resources or help sheets, there is so much information out there. The thing is, just don't get overwhelmed with all the content. Remember that when you see someone, they will present who they are, not the disease. So that's just always important that we're dealing with people, not the disease. It's not Mr. Smith, the dementia client, it's Mr. Smith who's living with dementia. So just to keep that real for them. Okay.
Nina, thank you so much. Big round of applause goes to you. So many comments coming. You're amazing. That's great to hear. Thank you for your excellent presentation. Great session, very informative. So big round of applause. Thank you so much. I've got, hundreds of comments coming through, questions coming through. So thank you very much indeed. And I will pass your email on to our interpreters. If we've got a little bit of time, I'll pass some questions through to you if you don't mind.
Sure.
It's really good to see some translators here as well. I know that there isn't a great number out there, and I know that I'm a translator as well as an interpreter, and I know that there isn't a lot of PD directed purely for translators as well.
Mm.
So I've got welcoming some translation-related questions, if you don't mind. First of all, one question is this. Great presentation, thank you very much. Do you have any advice for translators using non-complex language, for example? I'm a translator and an editor. How do you think the paperwork and written information could be set up differently to make it easier for people? For example, in plain English, especially for those reading English.
It's one of the biggest debates that we have, because so many of our communities don't even have a good grasp on their own language. So,
Mm.
you know, if you look at the long-term Italians that have been here, like my dad, you know, he wouldn't have been really very literate. He was a musician. So language, it's really hard. It's going to be so different for everybody else, and that's the complexity of translating. We do want things to be in an understandable format, and I think Dementia Australia is trying to relook at all of that. We There are a lot of help sheets that we have in other languages, and we do get comments from people saying that doesn't work in our community, or that's not the right language. So it is about being open and having discussions with the people that are doing the translations, but actual people from the community as well, because you want it to be accessible and appropriate. And it is difficult because you're never going to get it right for everybody.
We know now, especially after COVID and so many translations being needed so quickly, we now know that the source text is could be problematic because it's not in a language that is easily understood, let alone easily translated. So we do know that there is now work done within organizations to provide more plain English source texts, not just for
Yeah.
the English readers, but also to make it easier for translators as well, and to make it not just easier, but obviously more effective and more accurate as well.
Yeah, look, when we were trying, my dad's been in care. So when he turned 90, he was still living at home and then very rapidly declined and had to go into care. And in that very first part of last year where everything went into lockdown, it's really hard to explain to someone with dementia that the family's not visiting because we're not allowed into the nursing home. You know, so it was for my dad, we were just saying to him, there's a really big illness in the community. There's a lot of sick people and people can't come. So you do have to use the language that's appropriate for the person at the time. And that's hard. They're never going to have translated information. For Dad, he could still read the written word. And that was how we were communicating with him when he didn't have hearing aids that got lost. But it's that, you know, how do you have to work with what's going to be acceptable. And when we're dealing with dementia, it's very different to when you're dealing with someone that actually is able to comprehend what you're talking about.
Definitely. Thank you, Nina. I've got another one relating to translation from Sonia. Um, Can you highlight where translators are utilized or needed with regards to dementia? I guess what kind of assignments, jobs
Sure.
would we see translators being utilized?
I'll give you some examples of what I've done over the years, not just in this current position. So, for me, I have been a coordinator of services. I've been a coordinator of in home respite. Hopefully, you're aware of what that means. It just means that there's funding that people can go into someone's home and care for them in their home or take them out for the day, depending on what the carer needs. So when I have an interpreter come in with me, I'm looking at what my service is. So my in-home service, I'd be asking the carer, what do you need as support so that you can keep this person at home? So depending on what my service has been, if I was running a dementia daycare, which I've done in the past, I would have the translator working with me to find out, first to explain to the carers. Sometimes they don't understand what dementia day respite is. So we'd explain the process of that. We'd talk about what the person with dementia likes and dislikes. So it's very much a conversation to find out carers' needs and the person with dementia's needs and likes and personalities, and things that will help us work with them. Obviously, body language is something that in our area of work is very common. So I will see the way a person leans in or pulls away or pulls a face, sometimes they're all those non-verbal clues that I'm picking up on. Now, we have to, as people working with people with dementia, always think that they will understand something of what we're saying. So I always remind carers not to say anything inappropriate about the person with dementia in front of them. We can have those conversations away. But if I have a carer that starts to tell me about negative things, I will say to the interpreter, can you tell the carer that we can talk about that later? Because people with dementia can tap into bits and pieces of conversation, and that may set them off. So my community work would be more around a conversation, trying to find out what I can do to support this carer, and what would work for the person. So it's not just the support for the carer, it's also what is going to be acceptable and how do we do this for the person. And what you will find is that sometimes services have to start really slow, and that's the conversation we have. Maybe the carer has to be present for a while, maybe the carer joins in for a while until there's confidence built between the worker and the person with dementia. In the clinical setting, though, what you will find is that the doctors want a different type of, they will ask very specific questions about memory. They are trying to pinpoint how far into the illness the person is. So their questions, and look, they will have what we call a mini mental. You'll hear the word RUDAS used, which is more common for people from cultural communities.
We
The doctor, go on. Sorry.
we did a webinar on this last week with the assessment
Perfect.
tools. So those
Yes.
that attended last week, you'll know what Nina's talking about, the mini mental
Yeah.
and the rooters. Those
So the
that
doctors,
that haven't, they can actually watch the webinar as well.
excellent, because the medical side of it is very different. The doctors will be looking at, they'll ask them to do something, to draw something, so it's your job as an interpreter to just explain what the doctor has said for the person to do, because the doctor's trying to see what part of the brain is working well, what part isn't, how the person engages, what they can and can't do. So it's more of a physical and brain space type of assessment. Don't ever be scared of dementia, and don't ever be scared of it being too complex, because really you're just following the instructions of the person that's asked you to interpret. Now, for that person before that had the interpreter that asked you for the meaning, I would be saying to that person, what is it that you're trying to find out? Because unless you tell me that, I can't get a meaning. A meaning, it could be anything. You need to ask me a specific question to get a specific answer to understand the meaning. If that,
And
I hope that makes sense. But
like
that's what,
sorry, Nina, keep.
no, you're right.
And like you were saying, we're not there to add anything or omit anything, or to make sense of what the cold client is saying. Sometimes they are going to be nonsensical, and it is our job to make sure that we interpret everything the way it is said, as it is said, without adding anything or omitting anything, or clearing things up or
Exactly.
filtering things up.
Exactly, because that, for a person like myself, that part actually helps me understand what the client is experiencing, or what, like, say, even though it might not make sense, the way they answer gives me an insight into where we're at. So even a clinician, that answer that may not make sense at all to you as an interpreter, but a clinician will think, okay, they're responding like this, so this is where they're at, or this is what they're thinking. And if it doesn't make sense to me or to a clinician, they are the ones that should be asking you the next question, not asking you to try to interpret the meaning, because we can't do that. We need to get it from the person, either the carer or the person with dementia, how they present.
And the interpreter is not necessarily trained for that. It's the service provider that's trained for that. So it's not our
Exactly.
job to assess these things. We are there to
Exactly.
communicate what the clients are saying to each other. Just in regards to the translators, I think with the translation work, would you say that there's quite a lot of translation work within regards to maybe fact sheets, pamphlets,
Yes.
website material? Those are the kind of domains that translators can find themselves working within the dementia setting. Are there
Absolutely.
any other settings you think that they would potentially get work in, apart from translating information material?
in the spectrum of what I've done over the years, it really is about translating like paper, like my brochure, like it's not in multiple languages. But if we were going to get a translator, it's about the cost involved with all of that as well. When it's
Mm,
only a 2-year pilot, you can't really go into that. But even with our help sheets, the translators are there to translate, but then it's the organisation that needs to make sure that the language is correct, and that's how they would work with, translators. Because we did a video at one stage in Italian where I was asked to translate that into English for our organisation. And so it took me hours because it was in dialect, which is fine. It was a dialect that I speak as well. But some of the ways that the person was answering didn't necessarily translate very easily into English. So you had to get the contents. And that's the difficulty with translating it. It's not always word for word. We have to look at the community and what the community understands. And with some of the translated material that we've had, when we work with interpreters and translators, that this is their role, they will say to us that word doesn't exist in our language. Then we need to work with the translator to find out what that community would accept. And if there isn't a word, we may have to go back to changes in memory, or
that's right. Yeah.
we have to look at it, but that we can't. That's what the translators are there to help us with, because we don't know what each community is going to understand or accept, and that's where the translators hopefully are skilled and versed in their community to know what a community will accept, and that's where brochures, help sheets, presentations, these are all things that will be translated. What happens with me when I do a presentation is that I will present in English with an interpreter, and I will give the interpreter PDF of my slides so that they can look at the topics and how we're going to discuss them. We have a conversation before the session so that I can explain to the interpreter what I'm looking for. Then the interpreter's there on the day interpreting as I go. I need to remember to slow down and give them time to actually interpret what I've discussed. But I don't translate every slide because it's just the project's not big enough to be able to do that. But then I do work with the interpreter before the session so that they can see the slides and know what they're working with. If they have questions, they can come to me before the presentation or after. And then we debrief about how it went as well after the
Very good.
presentation.
So I think just when you say this, we need to point out how important a briefing and debriefing is with an interpreter and the service provider. Those few minutes before the actual session are vital. It is the strawberry on top of your preparation, of your years of education, hours of preparation for that particular session, and then having that last 3, 4 minute, 5-minute briefing just before the actual session, I think really adds to your total preparation. And then that debriefing, not just for to come to an agreement together how the session went and if things could be bettered for the next time, not just for the feedback, but also especially with interpreters who might be going in and out of these jobs. There's something called vicarious trauma that you see how sometimes disadvantaged people are, and they could be quite emotionally it could be quite emotionally challenging for the interpreter. And I think just to have that debriefing session with the service provider would really help in regards to reducing vicarious trauma as well.
Can I just add in? I agree with all of that. I think it's really important. What I noticed though is that you guys are overworked and overwhelmed because you are going across a lot of different things. Now, often I will have a interpreter that says, "I've got to finish by such and such time because I've got to be across country to another thing, to do." Open up the conversation about, look, I do have to leave right on the time, but can I get back to you? Can we have a conversation after? If there's things that you need to debrief about, because that debriefing is not only good for you, it's also good for me as someone using your service to understand if I can do things different too. So I know that you're overwhelmed, and a lot of my interpreters are going from job to job to job, and they don't have that time to debrief. And I think it's really crucial. We work in a very complex industry, and we work in an industry that's overwhelming. when we see what people are living with in the community. So just that self-care for yourselves is so important. Just, make sure that you've got someone that you can debrief with, because it's tough what we do, but it's so essential. So just, I really want to reinforce that.
Thank you again, Nina, so much for your presentation today.
Thanks for having me. It's been great.